Well, hello and welcome today to what is a special recorded session addressing some questions that came in during a recent webinar on NHS eProcurement with the ReTech Life Sciences team. If you'd like to see the recording of the webinar itself, you can go visit our Knowledge Center. Just go to retech.com, click on Knowledge Center in the top menu, and select Life Sciences Resources. You'll see the recording there from late in August. I'm sitting here with our presenters from that webinar, Gary Saner and John Lorenc, and they have agreed to address some of the questions that came in. We received many questions, and we're only able to answer a handful of them during the actual session. So without further ado, I'll read our first question here that goes to Gary. It says, our organization has been using HIBIC for our primary DI and UDI, but I understand NHS requires GTINs. We have Class 2 devices. What do we need to do to be able to submit to the NHS?
So that's a pretty frequent question that comes up, Dan. And the National Health Service has provided an extension for those devices that are using HIBIC standard. So there's actually a 1-year extension for the data recording and a 2-year extension for the presentation on the product label. So you can go to a compliance document from the National Health Service. It's entitled Compliance Timeline for Medical and In Vitro Diagnostic Device Suppliers, long title. But inside that particular document, you'll find a timeline of table for your Class 2 A and B. Normally, you would need to submit that data September 30, 2018, and with the extension for HIBIC, that would move out 1 year to 2019, and then 2 years for the extension on the labeling.
Great, thanks. And I'll just mention the slide that's being shown now is the regular timeline. Does not address the grace period, is that correct?
Correct, yep.
Okay. All right, thanks. Next question I'll ask John to address. Can you explain again the difference between product data and price data? I see that the deadlines are different.
No problem. And this slide will still be relevant as we're referring to the deadlines. So the product data is the data, as you can see, is first being requested by the NHS. And that's going to be product details similar to the brand name of the product, some characteristics such as does it contain latex and so forth. Whereas the pricing data would be specific to the sellable price of the product and could even be down to the trading partner level. So if you're, one particular business partner is paying X while another is Y, that type of information can be provided. However, the real details and specifics of what they want provided according to this timeline has yet to be released, but at a high level, that's essentially the difference there.
Great, thanks, John. I'll follow up with this question also for you. We're still working on FDA UDI. How can we combine our NHS compliance and data collection efforts with UDI and the upcoming EU UDI mandate?
That's a great question, an important question. Ultimately, what you're going to want to do is perform an analysis of your products and determine where they are sold so that you can work with a partner such as ReTech, who may provide templates and such that will identify which attributes are required for which use case, so you can combine efforts as much as possible and potentially make some decisions if you're receiving conflicting information, but ultimately it should be the same, and determine what should be the value of the source of truth for that value, and ensure it's consistently submitted to the US FDA, the NHS in England, and also the EU for UDIMED. But again, ReTech has templates and partners in place that would be able to help with that effort.
Great, thank you, John. Gary, next question is for you. Can you explain what purchase to pay means, please?
Yeah, that's a good question about the logistics chain and what this particular standard addresses, the scope of the activities. If we look at very early on, the manufacturer would generate a catalog of product information and make that available to the buyer, in this case, National Health Service. And for that particular activity, the GDSN is the standard to follow to get that catalog information to the buyer. The next step in the process would be for the buyer to select a particular item or multiple items and then place a purchase order. And at that point in time, there's a cutover to another standard, the PEPL standard, where the buyer is then able to place a list of items in a purchase order. The manufacturer, the supplier, needs to receive that order, acknowledge it, and provide an advanced shipping notice, so ASN, all our standard transactions inside PEPL. And then eventually, at some point in time, the actual delivery of goods takes place. Invoicing then is generated from the manufacturer to the buyer, and then payments occur at the end. So it's really the full logistics change of making a procurement and delivery.
Great. Thanks, Gary. I'll ask you another question. So data which is in the Good ID via the GDSN now also has to be submitted to the NHS via the GDSN with some additional data specifically required by the NHS, like packaging weight and dimensions. Is that correct?
Yeah, absolutely right. There's a second independent delivery of information. What you have in the FDA Good ID is good for regulatory purposes for FDA requirements and to meet those regulations. The second topic that we're talking about today, delivery of data to the National Health Service, is centered around commercial activities. And it does include some common fields. I think there's about 20% of those fields need to be replicated. But then there's additional new fields, and as the person that posed this question, I highlighted there's packaging weight and dimensions that are not sent to the FDA, but will be included in the National Health Service data record. So there's some commonality, but certainly a lot more unique fields that are needed for NHS to do the commercial transactions.
Great. Thanks, Gary. And I'll just mention, if any of the slides that you're seeing are of interest to you and you haven't yet received a copy of the slides from us, please feel free to contact the ReTech Life Sciences team. You can always send an email to MedDevice@retech.com, and we will provide you with a copy of these slides, including this full data elements comparison table between FDA UDI, NHS eProcurement, EU UDI, and the IMDRF requirements as well. John, next question goes to you. Is there a possibility for manufacturers of a small number of devices to submit their data directly to the NHS via web like it is possible with a Good ID?
At this time, unfortunately not. There is no direct interface where someone can enter information provided to the NHS. All data for the eProcurement program must be transmitted through through GDSN, so through a data pool. There's no other way to get the information there.
Thanks. Gary, this question is for you. We sell Class 1 devices to a distributor in England who then sells to an NHS trust. Who is responsible, the distributor or us?
Well, that is a question that was identified in some early scenarios from the National Health Service, but as of today, that question is still outstanding. There's some pending information from the National Health Service to guide distributors and manufacturers in their individual responsibility. So unfortunately, we could take some guesses, but prefer at this point just to say that we're waiting the final guidance updates from the NHS. It is expected shortly within the next few months.
Okay. Gary, next question is also for you. Is it possible to have FDA UDI HIBIC barcode on the same label with the GS1 barcode?
That is certainly possible. There's no regulations that we're aware of that the FDA disallows that. We have seen multiple barcodes on product labels, and that should not present a problem. It does pose a little bit of a confusion for those that are doing transactions when you do have multiple barcodes. Obviously, the question is, which one, or do I scan all, comes to play, and which, is required by my particular system. So, outside of that, there's no technical reason that you cannot have two barcodes matching the, the standards, but it could have different values, like the HIPAA identifier versus a GS1 G10 identifier.
Okay, thanks. John, next question for you. Can you advise this new process is being adopted by all NHS England trusts, and what is the timeline of implementation?
Yes, the process is being adopted by all the applicable trusts in England with the timeline that we see on the screen. We're receiving all our information directly from a NHS communication channel online, so anything that we're presenting today and with respect to timelines and such is received by then. You know that there could be some, hallway chatter as to assumptions of things that could change, but with what is formally documented and communicated, this is a timeline that has to be adhered to, and it is to satisfy all the trusts in England.
Thanks. We'll go back to Gary with this next question. Our Class 3 products have G10s at the production level, not at the catalog level, which is appropriate for the FDA. Is there any recommendation on how to handle the fact that the device will have a G10 that does not represent the catalog number?
Yeah, that's no problem to have G10s assigned to the base product and various levels of packaging. So you might have a hierarchy that has a couple levels involved. I'll take this opportunity to talk just quickly about the different record structure that is being used by National Health Service. GDSN basically has a different structure than the FDA Good ID. If you had submitted values to the FDA, you know that there's a single record that covers the base product, and then as necessary you append information to that base record that covers all the G10s for the packaging level. The structure is different inside GDSN, where only records that are related to a sellable, invoiceable product are actually published. And there is some ways in which you can make some binding and linking, but primarily the information that is sent over GDSN is for those products that are actually sold. So if you have something that is much lower in your hierarchy that is not actually sold, then it does not need to be reported to National Health Service through the GDSN.
Okay, thanks. John, this question's for you. Since this is not a regulatory-driven mandate, what happens if you are not compliant by September 30th?
Okay, so correct. This is not a regulatory-driven mandate. This is more of a commercial-driven mandate, as Gary mentioned earlier. So essentially, if you do not comply with this, you could be jeopardizing business continuity with your partners at the NHS with respect to supplying product and also being obviously reimbursed for the product. I would equate this to the use case that is happening in the U.S., where you'll see downstream business partners who you sell product to also requesting your data into the GDSN network, and perhaps even putting language to that effect in contracts. However, this has more of a formal body surrounding this request with something as formal as the National Health Service in England. So it's really, it would be, you're jeopardizing just business continuity.
Yeah, I think, let me add just a comment to that, John. What we believe will happen is that the trust will be able to see your competitor products and be able to select them off their new systems that they would be developing. And if they still wanted to do business with you, they would need to revert back to a legacy type of system. So in some regards, you're giving a little bit of ground to a competitor perhaps, and would need to handle future purchases through previous systems and outside the new plan going forward for the National Health Service. So, John, do you think that is in concert with what you're saying, that it's probably not a good business decision to delay?
Right. Yeah. Who knows how willing the NHS is going to be to keep going back between the separate systems. So yeah, it's certainly a risk that I would not be willing to take.
All right, thanks, John. Next question also for you. Did you get information on the GLN's organization within the NHS Trust? Is there a list of the GLN associated with each hospital or NHS location?
That's the information that's also we're receiving through the NHS workspace. So as of now, there are some GLNs that have been provided for testing purposes and such. And as other trusts are ready to participate in those tests, or as we approach go live, those GLNs will be available. The key is that yes, there are separate GLNs for the trusts and not a single GLN for the NHS, which then somehow the NHS knows how to send that data to which trust. So it will be variable based upon your business relationships with those trusts.
All right, great. A couple more questions here. Gary, if there's a change submitted to the Good ID, will that change automatically be made in the NHS database?
This goes back to one of the previous questions related to the two different databases, one being regulatory at the FDA, the other commercial activity at NHS. So the answer is no in this case. There's no collaboration or sharing between the FDA values in the Good ID and the National Health Service database. This question does bring up the conversation and point about having a database that serves both of those. For example, the RETEC database would be able then to take data and as necessary send it off to the FDA Good ID as shown on the screen here to meet your regulatory requirements. And then in the event that there's changes to attributes that affect the National Health Service eProcurement program, you could then select that particular target as your export and send the data off to that agency or that particular organization. So I think that kind of strengthens the argument for using a centralized database, using common data, using master data, and then being able to extract appropriate changed attributes and send the dedicated message through the corresponding gateway to the downstream target.
All right, thanks. One more question here for John. Can we list different and more products to the NHS than we do in the Good ID?
Yeah, absolutely. You should be listing the products that are applicable for those two use cases. So ultimately, if you have 1,000 products and only 900 of those are distributed within the U.S., you would be listing those within the U.S. Good ID, and all 1,000 are going to NHS trusts. You would be sharing the information for that additional 100 products there. So in terms of GDSN, with how the method in which you're doing that for the NHS, you have the ability to add all the products into the data pool, but select which particular G10s would be published to NHS trusts. So if it's all of them, great, simple, select all and send. But if that has to be cherry-picked, these for this trust, these for the others, you accomplish that by publishing out to those appropriate GLNs. And again, things such as the RETEC database and application or means in which that you could perform that action efficiently.
Okay, great, thank you. Well, I want to thank John and Gary for their time. If you have questions, other questions about NHS eProcurement, medical device data management, transmitting data through GDSN or UDI, please feel free to contact our life sciences team. We did try to consolidate some of the questions we received, so if we didn't address a particular aspect of your question, always feel free to contact us. You can send us an email, meddevice@readtech.com, or give us a call at the number shown on your screen. And I also want to invite you, please visit our Knowledge Center. You can get there through our homepage, readtech.com. There's lots of great educational resources there, including, again, the video of our full presentation from last month on NHS eProcurement. We hope to see you at our next event, and please feel free to contact us in the meantime. Take care.